Welcome. This is the New England Journal of Medicine. I'm Dr. Lisa Johnson. This week, October 10th, 2024, we talk about beta blocker use after myocardial infarction and treatments for cerebral adrenoleukodystrophy and for small cell lung cancer, a review article on hairy cell leukemia, a case report of a man with fever, myalgia, jaundice, and respiratory failure, and perspectives on Mpox, on addressing healthcare cost growth, and on confirmatory trials of accelerated approval drugs. Beta blocker interruption or continuation after myocardial infarction by Johannes Sylvain from the Pitié-Salpêtrière Hospital, Paris, France, and co-authors. It is estimated that 2 million persons every year in the United States and Europe have an acute myocardial infarction. The lack of contemporary large-scale randomized trials and of consensus recommendation on the duration of beta blocker therapy after myocardial infarction has resulted in lifelong therapy in many patients, making this class of drugs one of the most prescribed worldwide. However, the appropriate duration of treatment with beta blocker drugs after a myocardial infarction is unknown. Data are needed on the safety and efficacy of the interruption of long-term beta blocker treatment to reduce side effects and improve quality of life in patients with a history of uncomplicated myocardial infarction. In this trial conducted at 49 sites in France, 3,698 patients with a history of myocardial infarction were randomly assigned to stop or continue beta blocker treatment. All the patients had a left ventricular ejection fraction of at least 40% while receiving long-term beta blocker treatment, and had no history of a cardiovascular event in the previous 6 months. A primary outcome event, which was a composite of death, non-fatal myocardial infarction, non-fatal stroke, or hospitalization for cardiovascular reasons at the longest follow-up, with a minimum of 1 year, occurred in 23.8% of patients in the interruption group and in 21.1% of those in the continuation group. Beta blocker interruption did not seem to improve the patient's quality of life. In patients with a history of myocardial infarction, interruption of long-term beta blocker treatment was not found to be non-inferior to a strategy of beta blocker continuation. Thomas Jernberg from the Danderyd Hospital, Stockholm, Sweden, writes in an editorial that among patients who are already receiving beta blocker treatment and who meet the aforementioned criteria reported by Sylvain and co-authors, it appears safe to stop treatment with respect to serious cardiac events. However, because of the anti-ischemic effects of beta blockers, an interruption may increase the risk of recurrent angina and the need for rehospitalization. Regarding patients with a mid-range left ventricular ejection fraction, 40 to 49%, the uncertainty of beta blocker therapy is greater. Among patients with myocardial infarction and a preserved left ventricular ejection fraction, the findings of the REDUCE-AMI trial in April 2024 placed the use of beta blockers for secondary prevention squarely on the injured reserve list. The results of current ongoing trials will provide additional data on whether the use of these drugs in this population may be approaching final retirement. Hematologic cancer after gene therapy for cerebral adrenoleukodystrophy by Christine Duncan from the Dana-Farber Boston Children's Cancer and Blood Disorders Center and co-authors. Adrenoleukodystrophy is an X-linked metabolic disease caused by mutations in the ABCD1 gene that lead to a deficiency in encoding peroxisomal transporter ATP-binding cassette domain 1 adrenoleukodystrophy protein and the buildup of very long-chain fatty acids in tissue and plasma. Cerebral adrenoleukodystrophy develops in approximately 35% of affected boys before adulthood and results in progressive destruction of white matter, loss of cognitive and neurologic function, and early death if untreated. Gene therapy with elevaldogene autotemcel, ELI cell, consists of autologous CD34 cells transduced with lentiviral vector containing ABCD1 complementary DNA, lenti-D. This therapy has shown efficacy in clinical studies for the treatment of cerebral adrenoleukodystrophy. This current study evaluated the risk of oncogenesis with ELI cell. 67 patients who received ELI cell therapy in 2 completed phase 2-3 studies and an ongoing follow-up study were evaluated. Hematologic cancer developed in 7 of 67 patients after the receipt of ELI cell. Myelodysplastic syndrome with unilineage dysplasia in 2 patients at 14 and 26 months, myelodysplastic syndrome with excess blasts in 3 patients at 28, 42, and 92 months, myelodysplastic syndrome in 1 patient at 36 months, and acute myeloid leukemia in 1 patient at 57 months. The cases were associated with clonal vector insertions within oncogenes and clonal evolution with acquisition of somatic genetic defects. Lentiviral gene therapy for cerebral adrenoleukodystrophy by Florian Eichler from Massachusetts General Hospital, Boston, and co-authors. This phase 2-3 study evaluated the efficacy and safety of ELI cell therapy in boys with early-stage cerebral adrenoleukodystrophy and evidence of active inflammation on MRI. The primary efficacy endpoint was survival without any of 6 major functional disabilities at month 24. At month 24, none of the 29 patients had major functional disabilities. Overall survival was 94%. At the most recent assessment, with median follow-up of 6 years, the neurologic function score was stable as compared with the baseline score in 94% of patients. 81% of patients had no major functional disabilities. 4 patients had adverse events that were directly related to ELI cell therapy. Myelodysplastic syndrome with excess blasts developed in 1 patient at month 92. That patient underwent allogeneic hematopoietic stem cell transplantation and did not have myelodysplastic syndrome at the most recent follow-up. At a median follow-up of 6 years after lentiviral gene therapy, most patients with early cerebral adrenoleukodystrophy and MRI abnormalities had no major functional disabilities. However, insertional oncogenesis is an ongoing risk associated with the integration of viral vectors. In an editorial, Cynthia Dunbar from the National Institutes of Health, Bethesda, Maryland, writes that the clinical results reported by Eichler and co-authors are very promising, with 91% of the patients alive and without major functional disabilities at month 24, the primary endpoint. 94% of the patients alive at month 24, and stabilization of abnormalities as measured by MRI and neurologic function scores. At a median follow-up of 60.2 months, 26 of 32 patients were alive without major functional disabilities. The product ELI cell was approved by the Food and Drug Administration in 2022 on the basis of findings in the trials by Eichler and co-authors. But how do the data from Duncan and co-authors inform risk-benefit decisions regarding lentiviral gene therapies in general, and for cerebral adrenoleukodystrophy in particular? First, the high risk reported by Duncan and co-authors appears to be closely related to the inclusion of the strong viral MND promoter, an engineered artificial promoter comprising both the U3 region of a Maloney-modified murine leukemia retrovirus with long terminal repeats and an enhancer from the myeloproliferative sarcoma virus in the lentivirus. No cases of hematologic cancer have been linked to insertional genotoxicity from lentiviral vectors in at least 250 other patients who received hematopoietic stem cell therapies with other lentiviruses and equivalent patient years of observation. This editorialist fears that additional cases of hematologic cancer might arise over time in patients with cerebral adrenoleukodystrophy who received lentiviral gene therapy with this vector. The troubling oncogenic events reported by Duncan and Eichler and co-authors raise the bar for offering ELI cell autologous gene therapy for cerebral adrenoleukodystrophy. Autologous gene therapy for cerebral adrenoleukodystrophy has strikingly preserved neurologic function and extended life in patients treated early in the disease course, and this editorialist hopes that vector modifications can make the process less genotoxic in the future. Durvalumab after chemoradiotherapy in limited-stage small cell lung cancer by Ying Cheng from the Jilin Cancer Hospital, Changchun, China, and co-authors. Small cell lung cancer is an aggressive cancer that accounts for approximately 15% of all lung tumors. Approximately 1/3 of patients who receive a diagnosis of small cell lung cancer present with limited-stage disease, for which longest survival is achieved with concurrent thoracic chemoradiotherapy, with the use of platinum etoposide and early thoracic radiotherapy, followed by prophylactic cranial irradiation when indicated. However, most patients have a disease relapse within 2 years after starting treatment, and overall survival at 5 years ranges from 29 to 34%. No advances in systemic treatments for limited-stage small cell lung cancer have been made in the past 3 decades. This Phase 3 trial evaluated whether adjuvant immunotherapy with durvalumab, with or without tremelimumab, would have efficacy in 730 patients with limited-stage small cell lung cancer who did not have disease progression after standard concurrent platinum-based chemoradiotherapy. Durvalumab therapy led to significantly longer overall survival than placebo, median 55.9 months versus 33.4 months, as well as to significantly longer progression-free survival, median 16.6 months versus 9.2 months. Adverse events with a maximum grade of 3 or 4 occurred in 24% of the patients in each group. Hairy cell leukemia, a review article by Brunangelo Fallini and Enrico Tiacci from the University and Hospital of Perugia, Italy. Hairy cell leukemia, HCL, is a rare indolent neoplasm of mature B cells with hair-like surface projections that circulate in the blood and preferentially infiltrate the bone marrow and spleen. The clinical picture is characterized by male predominance, onset in adulthood with cytopenias and splenomegaly, a remitting relapsing pattern of response to sequential treatments, and an almost normal life expectancy with current therapies. The BRAF V600E kinase activating mutation is the genetic cause of HCL in at least 95% of cases and shapes key disease traits, including the peculiar morphologic features. Testing for the BRAF V600E mutation or protein and for HCL-specific immunophenotypic markers, including annexin A1, allows for the differential diagnosis of diseases that mimic HCL, such as HCL variant and splenic marginal zone lymphoma, which require distinct clinical management. Myelotoxic chemotherapy with cladribine or pentostatin, alone or combined with the anti-CD20 monoclonal antibody rituximab, is a highly effective standard care for patients with HCL. Chemotherapy-free strategies based on BRAF inhibitors, such as vemurafenib or dabrafenib, are increasingly used in patients with relapsed or refractory HCL and in those with active infections, and are being explored in a frontline context as an alternative to chemotherapy. A 37-year-old man with fever, myalgia, jaundice, and respiratory failure. A case record of the Massachusetts General Hospital by William Hillman and colleagues. A 37-year-old man was transferred to the hospital because of fever, myalgia, and hypoxemia. 9 days earlier, malaise, fatigue, and generalized weakness developed. The symptoms became so severe that he slept almost all day and night. Fever and headache developed, as well as achiness and stiffness in the arms, shoulders, knees, and legs. 5 days before this admission, the achiness increased, and the patient noticed that his urine was dark yellow. 2 days later, the patient sought evaluation in an urgent care clinic. Testing was negative for SARS-CoV-2, RSV, and influenza. He was instructed to get adequate rest and hydration. The next day, when the symptoms had not abated, the patient returned to the urgent care clinic. On examination, new yellow discoloration of the skin and eyes was observed, and he was instructed to go to an emergency department. Evaluation revealed multiple laboratory abnormalities, including leukocytosis, acute kidney failure, and conjugated hyperbilirubinemia. In this patient, the clinical syndrome and unique laboratory abnormalities were consistent with a diagnosis of leptospirosis. Leptospirosis is a zoonotic spirochetal infection that is most prevalent in tropical environments. Humans can acquire leptospirosis through contact with urine from infected mammals, often rats, or through exposure to a freshwater environment contaminated with the urine. Although leptospirosis is relatively uncommon in New England, this patient regularly walked his dog by a river. Later in the hospitalization, the patient recalled an episode in which the dog had jumped into the river. The timing of this episode would have been consistent with the time course of this patient's illness. The Mpox Global Health Emergency, a time for solidarity and equity. A perspective by Lawrence Gostin from Georgetown University, Washington, D.C., and co-authors. On August 14th, the Director General of the World Health Organization declared Mpox in the Democratic Republic of Congo, DRC, and neighboring countries to be a public health emergency of international concern under the 2005 International Health Regulations, the WHO's highest level alert. The previous day, the Africa Centers for Disease Control and Prevention declared a public health emergency of continental security, the organization's first ever declaration of a regional health emergency. This regional declaration and the WHO's early response, issued without waiting for Mpox to affect high-income countries, could offer a historic opportunity to mobilize life-saving resources according to the principles of solidarity and equity. Mpox clade 1 has been endemic in the DRC for more than a decade, with cases steadily increasing. In 2023, the country saw a sharp increase driven by a genetically distinct and more transmissible subtype, clade 1b. This year, the DRC has already reported more than 15,600 cases and 537 deaths. Many more cases remain undetected. Human-to-human transmission has primarily occurred within households, in healthcare settings, and by means of sexual contact. Tragically, most cases and deaths in the current Mpox outbreak have occurred in children, indicating that transmission is occurring by routes other than sexual contact. Priorities for an effective global response should include major investments in health systems, including diagnostics, surveillance, and the health workforce, risk communication, encouraging culturally appropriate behavior changes, equitable access to life-saving countermeasures, and sustained financing and action in the region. Mpox in pregnancy. Risks, vertical transmission, prevention, and treatment. A perspective by Jean Nashega from the University of Pittsburgh School of Medicine, Pennsylvania, and co-authors. The alarming surge in human-to-human transmission of monkeypox virus, MPXV infections, particularly in high-risk, sexually active, and reproductive age populations, along with the known association between MPXV infections and adverse obstetrical outcomes, highlights the urgent need for data to enhance our understanding and mitigate the risks of MPXV infection during pregnancy. Historical data on smallpox during pregnancy reveal high rates of miscarriage, premature birth, and maternal death. In 15 studies involving 830 pregnant patients with smallpox, 331, 39.9%, had a miscarriage or premature birth. Of 1,074 pregnant patients in 16 studies, 368 died. Case fatality ratio, 34.3%. The limited available data suggests that Mpox, like smallpox, increases the risks of severe maternal disease, miscarriage, and stillbirth. A 2024 systematic review of 7 studies identified 32 pregnant women with clade 2b MPXV infection between 6 and 31 weeks of gestation. Of the 12 pregnancies with reported gestational outcomes, half resulted in intrauterine fetal demise. Like smallpox, MPXV can be transmitted from mother to fetus with high viral loads found within fetal and maternal-fetal interface tissues, possibly contributing to pregnancy loss. Transmission from breastfeeding mothers with Mpox to their infants can also occur, potentially by means of close contact. To improve understanding of MPXV infection during pregnancy, an Mpox research program has been launched by the Mpox Research Consortium, which includes evaluating the accuracy of available diagnostic tools for MPXV clades 1 and 2, identifying MPXV reservoirs, and assessing the clinical efficacy of existing vaccines and therapeutics. Addressing health care cost growth. Why and how states should lead. A perspective by Elliot Fisher from the Dartmouth Institute for Health Policy and Clinical Practice, Lebanon, New Hampshire, and co-authors. Nearly 50 years ago, when healthcare accounted for only 7% of the gross domestic product, as compared with 17% now, The late Howard Hyatt called on physicians to work with government to put in place the data systems and policies needed to reduce wasteful and harmful care while improving health. Since that time, the financialization of healthcare has increased dramatically, to the detriment of the public and the medical profession. But reform that advances Hyatt's vision appears within reach in many states. Rising healthcare costs are like a balloon. As policymakers constrain spending in one area, affected organizations simply seek additional revenues elsewhere. Since spending is the product of volume and price, and since new services and products add to rather than supplant existing ones, policymakers need to see the full picture, establish system-wide constraints, and address the drivers of low-value spending and monopoly pricing. Without comprehensive oversight of money flows, sources and magnitude of waste, and opportunities for change, improvement will not be possible. Economists have long called for firm limits on spending growth. A key step forward has been the establishment of agencies charged with both these tasks. 9 states have launched programs to track and analyze statewide healthcare spending and establish reasonable spending growth targets. Because targets are aspirational, states also need to implement specific policies that can directly address the major drivers of spending growth. These authors recommend a comprehensive, mandatory approach. They believe that state-level reform is both possible and the most promising path forward. Confirmatory trials of accelerated approval drugs. Will imposing fines reduce delays? A perspective by C. Joseph Ross Duvall and co-authors from Brigham and Women's Hospital, Boston. In 1992, patient advocacy groups convinced the FDA to develop an accelerated approval program, which allowed new drugs to be approved on the basis of changes to surrogate measures, such as reductions in HIV viral load, that are reasonably likely to predict actual clinical benefits. Accelerated approval was later expanded to cover cancer drugs and corresponding endpoints such as tumor response rate. The goal was to expedite approval of promising new drugs for which definitive evidence of patient benefit was lacking. As part of the deal, manufacturers were charged with conducting post-approval studies to show that the drug does in fact benefit patients. If they failed to demonstrate clinical benefit or to complete these confirmatory trials, the FDA could withdraw the approval. In the 30-plus years since, accelerated approval has proven useful, but its implementation has revealed a persistent problem. Manufacturers of drugs granted accelerated approval have a limited incentive to complete confirmatory trials in a timely fashion. As a result, multiple studies have revealed delays in completion of confirmatory trials, with some trials delayed by years. Meanwhile, patients incur costs and medical risk from drugs for which conclusive evidence of clinical benefit is lacking. How then to ensure timely testing of drugs granted accelerated approval? A simple approach is already within the FDA's legal authority: fines. Under legislative authority granted in 2007, the agency can impose civil monetary penalties of up to $10 million on manufacturers that violate post-marketing requirements for confirmatory trials. In our images in clinical medicine, a 32-year-old man with well-controlled HIV infection presented with painful nodules on his forehead and a rash on his trunk. In the 3 months before presentation, he had had condomless sex with 4 male partners. Testing for Treponema pallidum was positive. His symptoms rapidly abated after 1 dose of penicillin G benzathine and completely resolved by the 3rd dose. A final diagnosis of secondary syphilis with osteitis was made. Although secondary syphilis is treated with a single dose of penicillin, 3 doses were given in this case owing to therapeutic uncertainty regarding the osteitis. In another image, a 25-year-old woman receiving daily prednisolone treatment for systemic lupus erythematosus presented with a 3-month history of erosive violaceous plaques in the antecubital fossae, popliteal fossae, and inguinal regions. She had been having condomless sexual intercourse with 1 male partner during the year preceding presentation. Testing for Treponema pallidum was positive. A diagnosis of secondary syphilis with an intertriginous rash was made. In patients with immunosuppression, the rash of secondary syphilis can be highly variable and atypical. This concludes our summary. Let us know what you think about our podcast. Any comments or suggestions may be sent to audio@nejm.org. Thank you for listening.